Hello everyone, and welcome to our module on pleural disease. So let's start by talking about what the pleura are. The pleura are two layers of tissue that surround the lungs. The first layer is called the visceral pleura, and that's what's attached to the lung itself. And the second layer is called the parietal pleura, and that's what's attached to the chest wall. And between the two layers is a space or cavity called the pleural space. Now the pleura are lined by cells called mesothelial cells, and you should remember that name because later we'll talk about mesotheliomas, and these are tumors that arise from the pleural cells. And the pleura secretes a small amount of fluid into the pleural space for lubrication, but it's a very small amount and it's always found there under normal conditions. The first pleural disorder we'll discuss is a pneumothorax. Pneumothorax literally means air in the thorax, and in this condition air enters the pleural space, usually because of a hole in the lungs that allows air to leak out. There are two types of pneumothoraces, the spontaneous and the tension, and we'll talk about both of these in the next few slides. In a spontaneous pneumothorax, air enters the thoracic cavity and the pleural space due to rupture of lung tissue. This usually happens secondarily to lung disease, so patients with lung disease have damaged lung tissue and they can suddenly have a hole develop in the lungs that allows air to leak out. This is often older patients with underlying pulmonary disease, for example, COPD. There are sometimes patients with no history of lung disease who develop a spontaneous pneumothorax. This is called a primary spontaneous pneumothorax. This usually occurs in patients who have subpleural blebs. These are common in tall, thin young males, and they can occasionally develop a spontaneous pneumothorax. The classic presentation of a spontaneous pneumothorax is the sudden onset of dyspnea. Sometimes patients will have pleuritic chest pain, and pleuritic chest pain is chest pain when you take in a deep breath. When you do that, you stretch the pleura, and if it causes chest pain, we call it pleuritic. And a chest X-ray is the test of choice for diagnosis. So this is an X-ray showing a pneumothorax, and if you look here on the right lung over here, you might think that this is normal lung tissue because it's black like you'd expect. But look over here at the left lung, you'll see that there are little faint lung markings, these little white lines in the spaces between the ribs. You don't see those over here on the right side. Notice that between these two ribs in here, there are no lung markings, and that's because there is no lung tissue there. This is the lung right here. It's collapsed from a hole in the lung, and what you're seeing out here is just air inside the thorax, and that's why it's a pneumothorax. The first-line therapy for pneumothorax is 100% oxygen. This is going to displace nitrogen from the capillary blood, and that's going to increase the gradient for nitrogen reabsorption from the pleural space. This is easier to understand with a picture, so let's imagine you have a space in the thorax here and it's filled with air. Well, air, as you know, contains both nitrogen and oxygen, so both of those molecules are going to be present here. Now let's imagine a capillary going past this area trying to resorb this air. Well, if this capillary contains no nitrogen, that'll create a huge gradient to reabsorb that nitrogen and shrink the pneumothorax. And the way you eliminate the nitrogen from this capillary right here is to give the patient 100% oxygen. It will bump the nitrogen out of the capillaries and fill them with oxygen only. That'll create a gradient for resorption of the nitrogen, and that will help shrink the pneumothorax. Sometimes 100% oxygen isn't enough and we have to place a chest tube, which is a tube inserted into the pleural space to drain the air. This is usually done for larger pneumothoraces, especially those that are more than 15% of the lung volume. Now let's talk about a second type of pneumothorax called a tension pneumothorax. A tension pneumothorax usually develops from trauma. If there is a laceration to the lungs, this can allow air to leak from the lungs and fill the thoracic cavity in the pleural space. In a tension pneumothorax, air enters the pleural space but cannot leave, and this creates a situation where air can build up in the thoracic cavity. To understand this better, let's imagine we have some lung tissue and it's become torn and created a flap in that tissue. Let's imagine we have air inside the lungs on the right side of the screen and the pleural space on the left side of the screen. With each breath in, air is going to push open that flap and exit the lungs and enter the pleural space. However, when the patient exhales, the flap will slam shut and not allow air to leave. As a result, over time, air is going to build up in the pleural space in the thoracic cavity, and this is going to create very high pressure. This can compress the lung and impair respiration, and in addition, it can even get pressure to be so high that it can compress vascular structures, and that can become a life-threatening emergency. This is a medical emergency. Patients who have a tension pneumothorax need an emergent thoracentesis and chest tube placement. Otherwise, that air pressure in the thorax can begin to compress vascular structures, and it can be life-threatening. And a key point to know about tension pneumothoraces is that the trachea deviates away from the affected side. So let's draw a trachea here, and it's going up and branching, and this is the midline of the chest. If you have a spontaneous pneumothorax, the lung volume shrinks over here, and the trachea will shift in this direction towards the side of the spontaneous pneumothorax. However, if this becomes a tension pneumothorax, air is going to steadily increase on this side and push the trachea this direction, and it will end up deviating away from the affected side. So make sure you understand that spontaneous pneumothoraces cause tracheal deviation towards the side of the hole in the lung. Tension pneumothoraces, on the other hand, cause tracheal deviation away from the affected side. Next pleural disease we're going to talk about are pleural effusions, and this is accumulation of fluid in the pleural space. Let's take a look at this chest x-ray. So over here on the right side, we do not have a pleural effusion, and you can clearly see the costophrenic angle, which is this angle here between the diaphragm and the rib cage. It's very easy to see it. Over here on the right, you can't see that angle. It's blunted or blocked from view because of the accumulation of fluid, and blunting of the costophrenic angle is a classic finding in pleural effusion. You can also see that this lower part of the left lung here is filled up with fluid in here, and you can sort of see a meniscus here. It's called a meniscus sign that you sometimes see in patients with pleural effusions. But the main findings are a general loss of the black lung fields and a loss of the costophrenic angle visualization. There are three general etiologies to pleural effusions that you should know about as a medical student. The first type is a transudative effusion, the second is an exudative, and finally there are lymphatic effusions. We'll talk about all three of these now. So let's talk about the transudative effusions first, and these pleural effusions happen when something drives fluid out of the capillaries and into the pleural space. And it's easiest to understand this with a picture. So let's imagine a capillary here, and blood is flowing past the pleural space, which is down here. I'll write the letters PS here. So if we had very high hydrostatic pressure inside the capillaries here, that could push fluid out of the capillaries into the pleural space. And high hydrostatic pressure is something that happens with heart failure, and this can lead to pleural effusions. The other way you can get a pleural effusion is if you have very little protein in the capillary space. If you have low protein here, it creates a low oncotic pressure relative to the pleural space, and therefore there'll be relatively high oncotic pressure out here, and that will tend to draw fluid out into the pleural space. And what could give you low protein in the capillaries? Well, nephrotic syndrome can give you low protein, and so can cirrhosis. So let's go back to our slide. The most common cause of a transudative pleural effusion is high pressures from congestive heart failure. But other causes are nephrotic syndrome, so you lose protein in the urine in nephrotic syndrome, and the plasma will have low protein and therefore low oncotic pressure, and that can cause an effusion. In cirrhosis, you have underproduction of albumin, so you get low protein in the blood, and that also can cause a transudative effusion. In these effusions, there's mostly fluid. There's relatively little protein because the capillary membrane is intact, and it keeps proteins inside the capillary, so there's not that much in the effusion. This will be important later when we talk about diagnosis. So mostly fluid in the effusion, very little protein in the effusion. And usually you treat these by treating the underlying cause. You don't usually drain these, but you treat the heart failure, treat the nephrotic syndrome, treat the cirrhosis. Contrast that with an exudative effusion. This is when you have fluid leaking into the pleural space from high vascular permeability. So let's go back to our drawing here. We've got a capillary carrying plasma past the pleural space down here. In an exudative effusion, this capillary is just going to become leaky from a pathologic process. And that means that plasma and proteins are going to leak into the pleural space. The result is you're going to get fluid in the pleural space that is rich in proteins. And this is different from transudative effusions. In transudative effusions, the capillary holds the proteins over here in the capillary space, but it lets fluid leak through. It's different in exudative effusions. There are many causes of exudative effusions, but the one we fear is malignancy. Patients who have tumors in the lungs or tumors that have spread to the pleura can get exudative effusion. Those metastases or those tumor cells can cause the pleural capillary beds to start to leak. Pneumonia can lead to exudative effusions. And as I said before, remember that in these effusions, there's more protein in the pleural compared to transudative. And exudative effusions usually require drainage as opposed to transudative ones where you can treat the underlying cause. So how are you going to tell the difference between a transudative and exudative effusion? Let's suppose you're faced with a patient who has shortness of breath and the chest x-ray shows a large pleural effusion. Well, what you're going to do is perform a thoracentesis. So you're going to stick a needle into the pleural space and withdraw a sample of the fluid. And you're going to send that sample of pleural fluid to the lab to test for two things, the protein level and the LDH level. It turns out that the level of these two markers in the pleural fluid can help you distinguish transudative from exudative effusions. Once you get back those levels, you're going to use something called Light's criteria. So Light's criteria says it's an exudate if one of three things is present. The first thing is a pleural protein level to serum protein level greater than 0.5, so this is a ratio. Second thing is the ratio of pleural LDH to serum LDH greater than 0.6. And then finally, it's an exudate if the pleural LDH is greater than 2/3 the upper limit of normal for LDH in the plasma. And the easy way to remember this is that exudates have very high levels of protein and LDH. So the ratio of protein or LDH to the serum protein or LDH is going to be high. It's going to be greater than 0.5 for protein and 0.6 for LDH. The final type of effusion I'll discuss in detail is a lymphatic effusion. This is also called a chylothorax. Chyle just means lymph fluid. And this is what happens when you have a pleural effusion made up of lymphatic fluid. And this happens when there's obstruction or injury to the thoracic duct. Recall that the thoracic duct drains lymph fluid, so if it can't drain, that fluid will back up and it can fill the pleural space. Malignancy is the most common cause, but it can also be caused by trauma, especially surgical. Many patients who have open heart surgery can have damage to the thoracic duct and they can end up with a lymphatic effusion. It'll be milky appearing fluid when you draw it out. Usually pleural fluid is straw colored or clear, but if it's milky appearing, that suggests a lymphatic effusion. And when you send it to the lab, you'll find very high levels of triglycerides, usually greater than 110. This is what's seen in pleural effusions that are made up of lymph fluid. Finally, you should know that there are many other types of effusions that you may hear mentioned on rounds and in the hospital. There can be a hemothorax when you have bleeding into the pleural space. These effusions have a high hematocrit, as you can imagine. You can have something called an empyema, which is where you get an infection of the pleural fluid. These effusions will have pus in them and a putrid odor, and if you send them to the lab, they'll grow out bugs. You can also have malignant effusions, which will have positive cytology. So these are usually exudative, like I said before, but when you send them to the lab, they'll find cancer cells inside the effusion. The last topic I'll mention in this module is a mesothelioma. This is a very rare tumor of pleural origin. Recall that mesothelial cells are what line the pleura. This is commonly associated with asbestos exposure. Asbestos is the only known risk factor for mesothelioma, and patients who were exposed to asbestos, usually from working in shipyards, can develop mesothelioma decades after their exposure. On imaging, you see thickening of the pleura and a big pleural effusion, and this has a very slow onset of symptoms, so patients will have dyspnea, cough, and chest pain that get worse and worse over months or even years, and then they'll finally come to medical attention, and you'll see a big pleural effusion and thickened pleura in somebody who many years ago had an occupational exposure to asbestos. Mesothelioma carries a very poor prognosis. The median survival is 4 to 13 months if you don't treat it, but it extends to only 6 to 18 months if you go ahead and have chemo. And that concludes our module on pleural disease.